And in this case, you find this incidental pulmonary nodule or mass, and it takes up FDG. You've just made a diagnosis of lung cancer in this patient and affected their management. So when we start talking about CT, I think we need to review a few basics here. So first off, when you look at CT, you need to be careful about what your window and level is. So here is just some examples of different window and level settings that allow us to see different things on CT. So this one is set to bring out things in the liver. This one is set to bring out things in the lung. This one's set to bring out things in the bone, and then this one in the soft tissues. Most of the software that is available for reviewing images, even in the cardiac side, will have presets that will allow you to adjust the window and level settings on the CT. And it's just really important to make sure you review all of those to make sure you're making all the findings. The software also allows you to have or look at multiplanar reformats. As you can see here, you can look in the axial, the sagittal, or the coronal planes. You can look at the fused images and toggle it on and off. And most of the time, they'll also give you the CT topogram, which can make it a little bit easier to find lines and tubes. It's important that you have a search pattern when you look at CT. Doesn't really matter what search pattern you use as long as you kind of follow it so that you don't overlook things. So I like to use region or organ-based search patterns. So I look at my lines and devices first, and I look at the heart, and then the lungs, the mediastinum, and so forth. Some people like to go inside to out. Some people like to go outside to in. It really doesn't matter as long as you make sure that you kind of follow your pattern pretty religiously so you don't miss things. Then finally, and this is really important, don't forget to look for abnormal activity in the findings that you see on the CT. In this case, again, we see this nice spiculated lung nodule in the left lung. It has increased FDG uptake. This is really concerning for a lung cancer. More CT basics. Remember that not all CTs are equal. For most of the studies that we're doing in cardiac nuclear medicine, we're using a low-dose CT mostly for attenuation correction and for basic anatomic localization. So if you look over here, you'll see here's a diagnostic chest CT, and here's our low-dose CT. As you can tell, there's a big difference in the quality and the slice thickness, and in what you can see. Here, it's pretty clear this patient has some pulmonary fibrotic changes. Here, it's much harder to tell. I think it's really important to know the field of view that you're looking at. Obviously, some studies we have a larger field of view, as in the case of a PYP study. The SPECT camera is covering a larger area, so you're responsible for a lot more anatomy. Whereas if you're doing, say, ammonia PET or rubidium, you're looking at a much smaller field of view that includes just the lung and the heart. And so it's important to know that field of view to know what anatomic structures you're going to be looking at. And then finally, I think it's really important to know your limitations. So for instance, in this case, we have an adrenal nodule here, but what's the next appropriate step? And it's okay if you don't know. Most radiologists are just a phone call away and are happy to help. So let's go on and move on to some of the incidentals that you might see. And what I've done is I've kind of broken these up into different organ systems. And obviously, not every CT finding that you could possibly see is going to be kind of in this list, but I try to hit some of the highlights. And a lot of these actually were seen over a week of my practice in cardiac nukes. So you can see pericardial effusions or calcifications. You can see pericardial cysts. One important one that has implications as far as risk stratifications and may actually help you interpret your cardiac study is coronary calcifications. Again, you can kind of look to see, are there no calcifications, or just even getting just a basic picture of how many calcifications there are can be really helpful, whether it's mild, moderate, or heavy. You can see cardiac devices and valves. You can see left ventricular aneurysms, and then you should be looking for left ventricular wall fat or calcification. So an example here, this is a good example of a pericardial effusion. As you can see here, this is probably a small pericardial effusion. It's relatively low density on the CT. and does not demonstrate any radiotracer uptake. Over here is another example of a small pericardial effusion, also with some bilateral pleural effusions. Notice here on the CT, they're pretty low density, the same with the pericardial effusion. This is a patient that has anasarca. This is a good example of a pericardial cyst. If you'll notice here, there's on the CT a pretty nice fat plane between the right ventricle here and this low attenuation structure, which is again fluid density. Hounsfield units of less than 10 are fluid density. And so this is just a good case of a pericardial cyst. As we talked about before, calcifications, and again, I think it's really important to put on your bone window for looking for calcifications. It brings them out a bit more. This is some pretty extensive calcifications in the LAD. This is a good example of what a cardiac device would look like. So in this case, this is a CRTD, and you can see actually on the CT topogram, helps you kind of localize where it is, with one lead here in the right atrium, the other one sitting in the right ventricle. This is what it kind of looks like on the CT. Again, bone windows kind of help because the attenuation of these cardiac devices is pretty high. So the bone windows help you see kind of where it is a little bit better. This is a good case of a calcified left ventricular aneurysm. You can see the calcification kind of in the wall of the aneurysm itself, which is a little bit pooched out. And then finally, this is just a nice case of subendocardial fat deposition. As you can see here on the CT, particularly on the coronal plane, you can see kind of what looks like fat density. And the best way is kind of compare it here to intra-abdominal fat. You see it has the same density here, but it's sitting along the endocardium. This would be consistent with an endocardial or a subendocardial infarct. Moving on to the lungs, things that we can see in the lungs, things like pleural effusions or calcifications, lung nodules or masses, pneumonia, pneumothorax, cystic or interstitial lung diseases, atelectasis, and then finally airway or endobronchial lesions or some type of airway or endobronchial narrowing. So this is another case of pleural effusion. As you can see here, we've got some low density collections here layering in the dependent portions of the lungs. In addition, there's a few kind of hazy airspace opacities that you see here, and this is compressive atelectasis. Note that the effusions here are relatively photopenic on when you look at the radiotracer activity, but the atelectasis can have a little bit of mild uptake even on ammonia. This is a nice example of a non-calcified pulmonary nodule. And I think there are some important comments to make about pulmonary nodules. We use the Fleischner Society criteria guidelines that were most recently published in 2017. And these apply to patients that do not have a history of cancer. And they kind of get broken down to, is the knowledge solid or is it semi-solid? And I'm going to go over mostly solid nodules because the semi-solid ones are really hard to see on the low-dose CTs and it's not very reliable. But for a solid nodule, if it's less than 6 millimeters and there's no history of cancer, a CT is optional. Once you start getting into 6 to 8 millimeters, it's kind of recommended that a diagnostic CT be done and that the patient gets some type of CT follow-up. Once you start getting into greater than 8 millimeters for the size of a pulmonary nodule, those are the ones that get more concerning and definitely need CT follow-up and may need evaluation with FDG PET or biopsy. It's important to look at the CT too, can kind of tell you a little bit more about the nodules. This one's pretty round and doesn't have a lot of irregular edges to it, and those can be a little less concerning than, say, something that has more regular edges. This is just a nice case of granulomatous disease. What you're seeing here is a pulmonary nodule, right? But when you put it on the bone windows, you can see it's clearly calcified. And then on top of that, we have partially calcified lymph nodes in the right hilar region and in the mediastinum here. And this is just a classic case of granulomatous disease. Where I practice, this is most likely to be histoplasmosis, but depending on where you practice, various granulomatous diseases can do this. This is a nice case of pneumonia, and this was actually not on a cardiac nuclear medicine study, but this was done on a diagnostic CT that came through the emergency room, fortunately, not on a cardiac study. But I just wanted to show you what pneumonia, particularly COVID pneumonia, would look like, since that's the reason we're doing this remotely. As you can see here, there are these kind of ground glass opacities here that are a little bit more peripherally located. There are multiple ground glass opacities, and this is just a very typical case of what COVID pneumonia looks like. This is a nice case of what we see with calcified pleural plaques, and you can see the calcifications here. Generally speaking, if the calcifications are bilateral, you're thinking asbestosis. If you see them just unilaterally, you might think that the patient had a prior empyema or pleural effusion, and then there's calcification associated with interval healing after resolution. This is a case of pulmonary fibrosis, which honestly is really hard to make on low-dose CT. However, in this case, what you're seeing here is you're seeing kind of some interstitial and ground glass opacities, along with some stacked kind of cystic looking lesions along the periphery of the lung here. This is fibrosis with, again, some interstitial changes. Really hard to make this diagnosis on low-dose CT, and so if you see something like this, you really should recommend a diagnostic CT for better evaluation. Incidental findings in the bones. Most common things that we're going to see are fractures, either in the ribs, in the spine, or sternal lesions. But occasionally you will see sclerotic or lytic lesions, and so you need to know how to handle those and what they look like. So this is just a really good case of a PYP study with a fracture, a rib fracture. You can notice here on the planar image, there is increased radiotracer activity. When you use the CT to anatomically localize it, it localizes to a rib. If you look here at the CT, there's maybe some very, very subtle buckling or irregularity of the rib. If you looked at it compared to other ribs, it'd probably look a little bit more buckled. And this is just a really common finding, which is a healing non-displaced rib fracture. Now, in this case, and this was borrowed from a diagnostic CT for a patient that came in with trauma, this is a more obvious rib fracture in case you wanted to see what that looked like. This is a